It's great to be here. Thanks very much for having me. This is actually the second year that Dr. Manchakanti tried to get me here, so I figured I had to say yes or else he would never leave me alone. I'm going to be discussing the APS guideline today, really obviously focusing on interventional therapies for this talk at this meeting. I think many of you are aware of the APS guideline and at least have read it or have at least heard about it. And I'm pretty sure I was asked to come here because many of you may disagree with aspects of the guideline or at least have significant questions about it. Before getting into the APS guideline specifically, I did just want to say that APS is not alone. There are many very credible and very influential groups led by very bright people who have a lot of experience doing this kind of work, who have independently come to similar conclusions about a lot of interventional therapies. And it's not that there's a vast conspiracy out there against interventional medicine, or at least not that I'm aware of. It's really that we're working from a shared understanding of what constitutes good evidence or actionable evidence. And I'll explain what our rationale and methods are during this talk. Really, our underlying premise when we do this work is that, for all patients, whether they've got low back pain or not, and for all interventions, the things that we do should be from a basis of strong science and from a certainty about what we're doing for patients. That's our responsibility to patients, and that's really where we're coming from. Conflicts of interest. I have no conflicts of interest relevant to the topics in this talk. Research funding is from AHRQ, the American Pain Society, and the Drug Effectiveness Review Project. I'll go over some evidence-based medicine principles briefly and then spend most of the time talking about the methods and our rationale, as I said. Just to orient everyone, this was a very long, arduous process. It began in 2004. My twins were just 6 months old when we began this thing, and by the time the interventional therapies guideline was published, that was May of 2009, I believe. They're in kindergarten, so a huge time effort. This is a partnership between ACP and the American Pain Society. ACP is the American College of Physicians, the largest specialty society in the world. For the primary care guideline, the VA and the DoD also participated and have implemented the guidelines in their system. The VA is the largest managed care system, essentially, I think, in the world. No other societies were formally involved. We did ask societies to suggest experts who should be on our panel, etc., but there was no other formal partners on this project. APS was the sole funder for the interventional therapies and surgery guideline. The evidence review was conducted at the Oregon EPC. We're not federal employees. There was some publication in a pain physician that said that I was a federal employee, and that's simply not the case. We had a series of 3 face-to-face meetings to develop the guideline. In terms of the panel composition, initially we assembled a multidisciplinary panel. We tried to get together all of the stakeholders who are interested and relevant for low back pain. We had over 25 members in the panel, over 15 specialties and organizations were represented, everything from primary care, chiropractic, PM&R, interventional pain medicine, surgery, psychiatry, etc. We had 3 co-chairs. It was a triumvirate. Internal medicine was one, interventional pain medicine was the second, and surgery was the third. We tried to cover all the bases. This was our leadership. There were 2 interventional pain physicians total on our panel, as well as 1 PM&R physician who does interventional procedures. We thought that was pretty decent representation considering there was only 2 primary care docs. We reported the financial conflicts with the guideline. There were none to declare related to interventional procedures. For the interventional surgery guideline, we actually added a couple of people. We decided we wanted to make sure we had enough clinical expertise, so we invited 3 societies, including ASIPP, to recommend additional experts to be included as part of a working group. They weren't invited as being formal members of the panel because the panel was already set, but we wanted them to be present in an advisory capacity. All of the panel and work group members agreed to be listed as members of the panel and or the work group at the end of this process. So there have been some statements that said that people have disavowed the guideline. None of this happened before the guideline was published. Everyone agreed to be listed on the panel or as a member of the work group not necessarily as an author on the papers, which is a different issue in terms of who can get authorship, but at least as working members or panel members. This thing goes through extensive peer review. By the time the guideline was published, it had been peer reviewed by over 40 external experts. It also underwent a separate independent journal peer review process. So there's a lot of stuff that goes through. As you know, one of the papers was published in Annals of Internal Medicine, one of the highest impact journals, medical journals out there. It's been downloaded over 150,000 times. The spine paper also went through an independent peer review process. That's totally separate from our own peer review process. This is a quote that everybody has about evidence-based medicine. I'm not going to repeat it. I think Dr. Manchakanti has it in his slide also. This is from David Sackett. So what does evidence-based mean? When we talk about something being evidence-based, we mean that it's a comprehensive, systematic, open-minded review of all of the evidence. And we want the evidence to determine the conclusion, not vice versa. This means that you don't only cite stuff that supports a preformed conclusion or agenda, and you don't just use evidence when it's positive and ignore it when it isn't. An evidence-based decision process makes use of an unbiased, systematic review of the evidence, but it doesn't look at all evidence equally. We emphasize the best evidence, or we should be emphasizing the best evidence. You use rules to link the evidence to the recommendations, and you produce recommendations that are clear and defensible. This is from David Eddy. He was one of the kind of fathers of evidence-based medicine from JAMA back in 1994. And the question is, when should a new therapy be used? Well, he proposed that there should be convincing evidence that compared with no treatment, the treatment is effective in improving health outcomes. Second, compared with no treatment, its beneficial effects on health outcomes should outweigh harmful effects. And third, compared with the next best alternative, the treatment should represent a good use of resources. I think these are pretty basic principles, and they're laid out pretty clearly. Most people would agree with these. Just wanted to show that this is a quote from the president of the British Pain Society, from BMJ, regarding the president of the British Pain Society, who was forced to resign his position because the British Pain Society didn't agree with the guideline that he worked on with UK NICE, that's the National Healthcare Group in Great Britain. And this is their quote: "The BPS provided evidence to support the clinical effectiveness of such procedures," referring to interventional procedures. "The guideline development group did not consider evidence presented from cohort studies and clinical case series in its deliberations on these or any other treatments. We think this was misguided." So we're going to examine this statement in some detail here. This is a hierarchy of evidence that everybody has seen. A well-designed randomized controlled trial is at the top, and then you go down to the non-randomized studies, the cohort studies, case control, etc. Opinion is sometimes listed as a type of evidence, but opinion really isn't evidence. It's opinion. Your opinion is based on something. It's either based on good evidence or lousy evidence or nothing. But it's opinion, and opinion does come into play. People have to make judgments about what is better evidence and what isn't when we're looking at this. But opinion is always based on something. It isn't evidence itself. When looking at the evidence hierarchy, the principle is that evidence from higher on the hierarchy can still be weak if it's not done well, right? All those things have the caveat that it has to be well designed. So if you can have low quality RCTs that really don't help you because they're designed poorly. We've alluded to that earlier today. Simply describing the type of evidence, therefore, to support a guideline recommendation isn't sufficient. You also have to look at the quality of those studies, and you also have to look at the magnitude relative to harms, which a lot of guidelines don't do. They just kind of say, yeah, we think this kind of works, and they have there's no judgment about how well something works or how well something works relative to harms. Uncontrolled designs severely limit our ability to understand efficacy. These are some of the reasons. There's lots of reasons people can appear to improve even though something actually doesn't work. So it can happen just by chance. The natural history. Everybody here knows that if you have acute low back pain, you can do anything to somebody and they'll get better. You can hit them on the head with a rubber mallet and they'll get better over the next 3 or 4 weeks. That's natural history. Regression to the mean is quite common. It refers to the fact that even in people with chronic low back pain, that there's a fluctuating course. People tend to present for care when they're doing a lot worse with their pain. The natural history after that is that they'll get better. That's regression to the mean. So if you just follow them up a week or two later, they tend to be better. This is kind of the natural ups and downs of clinical courses. Placebo effects, of course, can be very strong. We know that. We know that people, they're used to their placebo effects with sham surgery and things like that. They can be very strong, and they can actually overpower other things. And these are very often related to perceptions of how effective someone thinks a treatment is. Hawthorne and other nonspecific effects, these refer to effects related just to paying attention. People like being paid attention to, and if you are enrolled in a trial and somebody's calling you all the time and asking you how you're doing, people tend to do better with that kind of TLC. All of these are what we call nonspecific effects. They're not related to the effects of the treatment at all. So the problem with uncontrolled studies is that, number one, they're often retrospective with very limited data on baseline characteristics. You don't know how they selected these patients. It's difficult to identify in inception cohorts. Dr. Pearson earlier had talked about you really need to do a good job prospectively identifying how you select these patients to be studied. It's often not the case. This is often a convenient sample of people who happen to do well and happen to still be followed in the clinic. They're usually not blinded, which is a problem, of course. And so you can't distinguish the specific effects of treatment from nonspecific effects, particularly because there's no control or comparison group. There's also a very high potential for publication bias. Very few people report or write up a case series where their patients didn't do very well. And there's no registry to track these kinds of studies anywhere. So we know that there's a high potential for publication bias. So uncontrolled studies can supply useful information, but really only in limited circumstances. This is when the outcomes are very obvious, when the outcomes are immediate, and when the treatment causes dramatic changes to the outcomes, so dramatic that they can't be explained by any other factor. People talk about the parachute example where you don't need RCTs to demonstrate that parachutes work. There's lots of other examples, though. You don't need a randomized controlled trial to show that eyeglasses fix vision. Nobody's ever going to do a randomized controlled trial of that, and it would be dumb. It would be a waste of resources to do that. Same with cataract surgery. There's plenty of other interventions like that. The problem is, though, for chronic low back pain, the effects are typically small or moderate. We'll talk about what those effects are, but generally, on average, you're talking at best a point or two on a 10-point pain scale. And we know that chronic pain is subject to many psychological and placebo effects and other factors. This has been shown over and over again. So it's very hard to make a case that these uncontrolled studies can give you very much useful information. This is a slide I borrowed from Rick Dio. This is estimates of effectiveness from uncontrolled studies. As you can see, everything looks about 80% effective. And I think that this slide maybe tells us a little bit more about natural history and nonspecific effects other than whether we know what works and what doesn't. You could literally look at any intervention for low back pain, even things we don't think really work anymore, things like coccygectomy for tailbone pain and sacroiliac fusions and stuff like that. You always get 80%, 70 to 80% response rates in uncontrolled studies. We don't think this is reliable evidence. These are therapies for low back pain that have been thought to be effective based on uncontrolled studies. So bed rest, sacroiliac fusion, coccygectomy, prolotherapy, intradiscal steroid injections, et cetera, et cetera, et cetera. The list is very long, and this is why we don't trust uncontrolled studies.